trouble breathing, their sats are running a little low, an oxygen delivery device like a flow meter works perfectly for them. And I'm gonna go at this from a patient safety standpoint. So if your patient is on a nasal cannula and they are not doing well and their sats are low, what you're gonna pull out next is gonna be called a non-rebreathing mask. You're gonna know it from everything else because it's got this, what we call a reservoir bag on it. When this is hooked up to an oxygen flow meter, push down on this one-way valve, this bag fills up. Once this bag is filled up, then you can put it on your patient. Okay. This is run no less than 10 liters per minute. I don't care if you remember that or not, you put it on, you crank that flow meter all the way up, you fill this bag up, you put it on the patient, what's the next thing you're gonna do? You're gonna call respiratory. Because if a patient's requiring this, something's going on with that patient. And we need to both be there, respiratory and nursing, and figure out what's going on and do some sort of intervention. If you have a patient on one of these, you do not turn down the oxygen flow meter to wean them off of them. This has to be on a minimum liter flow, otherwise the patient will smother in this mask. So that's why we ask, if your patients are doing well and you feel like their oxygen needs to be weaned, let respiratory know, because the different devices operate differently, and it's not as simple as just turning down the oxygen on the wall.
Kelly, don't forget to tell them about not covering up those.
Yes, that's on my.
On your your Venturi
mask. This is another mask that you will see. This is called an air entrainment mask, and it does give a very precise amount of oxygen. I will never ask any of you to put one of these on a patient, but you will see them on patients. Rarely, but you will see them. What I want you to notice is there's something down here that's got holes in the side of it. Those are air entrainment ports, and they must stay uncovered. So if you've got a little old lady that's cold, and you know how they like to get their, don't let her put her blankets over these. If you cover these up, it does significantly change the amount of oxygen that is coming out of the mask. So patient safety. Does anybody have any questions about those three things? This is an air entrainment mask, also called a Venturi mask. I'm not sure what your book calls it. Do you know what your book
Venturi.
Venturi. It's called Venturi a lot of places because it operates on the Venturi principle of air entrainment. All right.
I brought my my inhalers if you want
to.
to.
You brought your inhalers. Okay, so one of the things I want to hit is wheezes. You've got wheezes on COPD. I'm sure you've got wheezes on asthma. Sometimes pneumonia, if you've got retained secretions, can cause wheezing. But if we got into cardiac patients have wheezing too. Pulmonary edema causes wheezing. So that's one of the things, as a respiratory therapist, from a patient safety standpoint, I want to stress with you is that all wheezes are not caused by respiratory issues. Some wheezes are caused by cardiac issues. If the wheezes are caused by a cardiac issue, giving them respiratory treatments are not going to fix the wheezes. So if you've got a patient with, have they done any cardiac yet?
Mm-mm.
So if you've got a patient with a lot of fluid in their lung from heart failure, they may wheeze. They may wheeze very pronounced. You may walk in the room and hear them wheezing. That's not a respiratory wheeze. That's a cardiac wheeze. So that gets treated differently. So just, I'd like you to understand that not all wheezing is a respiratory issue. But Dawn was nice enough to bring some inhalers. And I see over there you've got talking about your SABAs and your LABAs with your COPD. So we have bronchodilators that we give often to patients. We give them through small volume nebulizer. We give them through inhaled MDIs and DPIs. If you are going to, and more we're having respiratory do disease management, case management, and work with COPD patients because it's such a big issue with COPD and the 30-day readmissions for insurance. But you all do end up having to do some MDI instruction. So,
And tell them what MDIs are.
MDI stands for meter dose inhaler. Your medication is suspended in here. It's an aerosol, which means it is a particulate medication in a propellant gas. When I squeeze it, you can see the aerosol come out into the room. It's metered, which means it's going to give a precise amount of medication with each depression, each puff, each inhalation. So the key things with an MDI, a meter dose inhaler, is that it needs to be shaken for at least a minute before use. If it has not been used ever, or it's not been used in the last 24 hours, then you need to prime it, which means you need to do this with it and squirt it out into the air. Okay. That gets the holding chamber inside here, gives the correct dosage so that when the patient takes the next dose, it will be the correct amount of medication. If it's not used within 24 hours, that chamber loses its prime, so the patient will not get the correct dose if it's not primed after 24 hours. Now, it looks like it's a wonderful little mouthpiece there, and you would have the patient put it in their mouth, right, and suck in on it. Seems like that would make sense. That's not how you do an MDI. The MDI, you want to have the mouthpiece in front of the mouth. A lot of times what I will tell patients if they have trouble coordinating is they can rest their top teeth on it, but not to seal their lips, because you want the patient to draw in airflow from the room when they breathe in their MDI and help that propellant go down into the lungs. If they seal their lips around here, they suck the gas through here and it makes the gas very turbulent, and it makes the gas in the mouth turbulent and the throat turbulent, and what happens is all of those little particles impact the side of the mouth and the back of the throat, and nothing gets down to the lung. And we're treating the lung with this, not the mouth or the throat. So, in front, and they need to inhale and depress at the same time. Now, if I made all of you go out and run around that circle for the next, say 5 or 10 minutes, and then said, okay, now I want you to take this and hold it in front of your mouth and take a nice slow deep breath and squeeze this while you take that slow deep breath, and then hold that breath for the count of 5 before you exhale. How many think that they would be able to get the proper medication? That's how our COPD people feel, which is why they get readmitted every 30 days, because they can't take this stuff properly because they're short of breath. And you know what one of the side effects of this is? Tremors. So their hands are shaking like this, and their breathing's labored, and they're trying to time all that. So we kind of set them up for failure when we send them out. So we have things called spacers. You don't have spacers.
I don't. No, I started to cut one off of a tube, and I forgot
We have
to.
things called spacers. They're kind of clear. They're about this long, and this hooks into it. And you can dispense this into the spacer, and then they can breathe in off of the spacer.
The book does have pictures in it,
Okay,
so you all can see that.
They do have spacers, and they go over their mouth. Yep. It is important to encourage doctors to order spacers. If your patients are going home with these, make sure they have them ordered, and then make sure the patients understand to use them. The reason they don't like to use them is because it's really easy to throw this in your purse or your pocket. The spacer's a little bit bigger, a little bit more cumbersome, and so they don't like to keep up with it. It's a pain. But if they understand they're not gonna get their medication unless they use the spacer, then they will be more out. What do you want me to do next? We have 3 minutes.
Well, let's talk about, let's do this little activity.
Okay. You wanna give them straws?
Yeah. Let's give them these first. You all are gonna get a straw to take home with you. Over the. So, take this coffee stirrer. Right here. Okay, so it's over here. Oops. I ordered them off of Amazon, $7.
That's where you get everything, Amazon.
The only thing I remember seeing was like sweet actually hatched when I go to this movie and they had
Okay, so talk to, Kelly, I'm gonna let you talk to them about, the difference in airway with the larger.
I didn't get one.
Oh, you get one. So if this is your airway, okay? Everybody, I want everybody to put this one in their mouth and start breathing on it. Just while I'm talking, you're just gonna leave it there and that's gonna, you're just gonna keep breathing on it. Okay? So that's all you can breathe through is that. Seal your lips around it, no breathing through your nose. Okay? So that's your airway. Okay? Now, one of the things that our respiratory students learn very early in their program is that when you decrease the radius of the tube by half, airway resistance goes up 16 times. Okay? So if we were to decrease this by half, your work breathing is going to go up 16 times. Now, this is about the size of a 9 endotracheal tube. An endotracheal tube is that tube that we put down people to breathe for them. Okay? We don't use 9s on anybody because they're big. So we usually use somewhere between a 7, 7.5 up to an 8. So the tube that we normally put in people is smaller than this. Now, we talked about COPD and asthma, which is a 3-pronged disease that consists of airway swelling, increased mucus production, and bronchoconstriction, or the spasming of the muscle around the airway causing it to clamp down. Those things cause obstruction, like we talked about earlier, obstruction in the airway. Airway gets smaller. So now I want everybody to flip over to their coffee stir stick and do the same thing while I continue to talk. All you can breathe through is that coffee stir stick. So is everybody feeling really good right about now, breathing through that? How would you feel about breathing through that if I said you need to get up and walk down the hallway and go to the bathroom? Or you need to cook? Or you need to go get the mail? Or you need to pick the kids up? So the things that we're doing to COPD, and you can quit doing that. The things that we're doing to COPD patients are things that we're trying to intervene and get them from the coffee stir stick closer to something like this so that they can have a better quality of life. One of the things we teach is pursed lipped breathing. Does your book talk about pursed lip breathing?
Yes.
With COPD, a lot of the patients have more trouble actually exhaling than they do inhaling. They can get the air in because when you breathe in, you have a negative pressure in your chest. Air flows from the atmosphere into your lungs. But when you go to exhale, the pressure in your left chest turns positive, and it actually, with the damaged tissue in a COPD or an asthmatic's lung, it actually closes the airways. It pushes down on the airways and closes them so they can't force that air out. Well, if you can't force air out, there's no room for the next breath to go in. So what that pursed lip breathing does is provides a back pressure, and if you do it, it's in through the nose and then out. And you can feel that back pressure in your lungs when you do it, and that actually is holding their airways open to allow them to exhale so that they can take a next breath in.
And that's part of that breathing retraining that I was talking about. That's one of the things that patients are taught when they're taught breathing retraining to try to do diaphragmatic breathing is pursed lips breathing. You'll see oftentimes, and in your book, it shows a picture of a patient with COPD and the way that they're sitting in a chair. And it's very classic the way that guy is sitting in the chair. He's all kind of slumped to the side, and you all will show that to her. So when you're talking about teaching these patients, we've got to teach them how to better breathe and how to train themselves to take longer expiratory breath, and so that they can get those out. So I know we've gone over just a minute or two, but does anybody have questions for Kelly in relation to some of these modalities or any of the disease processes?
Yeah, I love questions. And it doesn't have to be limited to today. If you see me in the hallways, if you see me in clinical, wherever, if you need to pick my brain about anything that has anything to do with respiratory, feel free.
She's a great
I love what I do.
resource. Yeah, she does.
Okay, I'm gonna tell you about a patient I had in clinical. And this has not been too long ago. I was called to a rapid response. Another therapist had recently drawn a blood gas on the patient and then had gone to do other things. When I got to this rapid response, the Dynamap was not cycling. So what's the first thing that you need to do?
The Dynamap is not cycling. What do you need?
They keep putting the button and it keeps alarming and not reading out anything.
Manual.
Thank you. So manual blood pressure was taken and the blood pressure was 80. They did a blood sugar and it was 30. Have you all had blood gases yet? You studied blood gases yet? Blood gas results came back and the patient's pH was 6.9 and the CO2 was 110.
Oh.
So, how long do you think it took the patient to get like that? Do you think that happened like that?
No.
How many people do you think had something to do with that patient during that deterioration that could have intervened and stopped that patient from going down to intensive care and being put on a ventilator? That's why all this is so important. That's why what she says about working as a team and paying attention to those signs of deterioration with your patient are so important. Because I guarantee more than one person missed multiple signs. Because that didn't happen like that.
One of my favorite things is to say, prevent clinical deterioration in your patient. My students a couple of semesters ago got me a shirt that says prevent clinical deterioration, because I want your skills to be good enough that you recognize the normal when there's something abnormal and that you can intervene, which is that nursing process that I talked about when we first started class. It's the complete process, and it's a reassessment, and it's intervening again, and putting in new interventions if those older interventions are not working, or if the patient has reached that level and they need a new intervention. Okay, so that's what we want you to do, and working along with respiratory. That's why I wanted Kelly to come in so that we can see, we're a team effort. Not just in intensive care, not just in the ER. We're a team effort in the entire hospital. Because if my patient is going down the tubes, I'm going to call rapid response, and one of the first people that's probably going to get there is going to be respiratory, because a lot of times it's a respiratory issue. And if it's not, then they've just gotten a good workout. So
The big thing is we are your specialty. We are a specialty where you all are very broad and take in everything. We have our niche and we need to work together. We may cover multiple floors, so we don't get the luxury of being able do. And we depend on you all to see those signs of deterioration and to let us know if you think something bad might be going on. You know, we depend on each other.
All right, questions? If not, I'll do these two after you all leave, and I'll upload those as well, okay? I do have some, papers with blood gases, if anybody's interested, there's some practice, blood gas sheets, and then, there's some, different blood gases there for you all to review. So you can get these, I'll lay these back here on the table and you can pick them up if you want them.